Okay, hi everyone, welcome back. So we're still on the cardiovascular system. We're going to try to transition to the respiratory system in the middle of this lecture. You don't need to warm up top hat today, so we're just going to go straight and try to catch up on some time because again, luckily we have the week after spring break, and that week, like that one, unfortunately I have to record because I'm doing that book writing workshop with the rest of the A&P professors. So we do have a week before that, but again, we need to finish the respiratory system as well. And again, we're not covering the lymphatics and immune system until exam 3, so you can skip that chapter for now. Okay, so where we left off with the last lecture, we were talking about blood flow and blood pressure. And when we talked about those precapillary sphincters, the cool thing is that they can actually constrict and relax by sensing the chemicals and heat and other things in their environment. So it actually doesn't involve the nervous or endocrine system. This is something we call autoregulation, where sometimes tissues can adjust their own blood flow without needing help from the nervous or endocrine systems. But the thing is that the nervous system and the endocrine system can affect the rate of blood flow and pressures throughout your cardiovascular system. So we'll touch upon that really briefly for this class. Okay, so what we have are baroreceptors. And if you took here the A&P1, you remember that baro refers to pressure. So baroreceptors are cells that detect pressure. So what we have with baroreceptors is that they detect pressure and then they're going to send signals that either cause a reflex or they send signals to the central nervous system that sends signals back to adjust and maintain blood pressure. And there's also things called vascular or nervi vasorum or vascular nerves. So your vessels also have nerves themselves, and they can also trigger the contraction of smooth muscles within the nerves. Now this is what we have. Remember that homeostasis is all about balance, maintaining optimal conditions for your body and the cells and tissues inside your body. Now what we have here are changes in homeostasis. Remember that homeostasis is not just about maintaining a comfortable range, but it allows your body to kind of expand beyond that range, but you have to bring it back eventually. So your body can experience increase or decreases in blood pressure, but is it going to maintain that increase or decrease? Eventually, your body wants to restore it to an optimal homeostasis and blood pressure for your own body. So say you have a spike in blood pressure. How does your body bring down blood pressure? Well, what can happen is that you can have increased baroreceptor firing. So again, these baroreceptors, they detect pressure. So this is going to increase the activity of these neurons that detect increases in pressure. And what they'll do is a multi-pronged effect. And notice that we have 3 things here. And then let's break this down a little more. So what we have we have our medulla oblongata in our brainstem over here. So here we have the sympathetic cardiac nerves that innervate the heart, but we also have parasympathetic, and again, all about the autonomic nervous system. Remember that sympathetic is associated with the classic fight or flight, and vagus nerve and parasympathetic is associated with the rest and digest. So it's kind of like putting on the gas versus putting on the brakes. Now with the heart, what's going to happen with this baroreceptor firing and increased activity in these baroreceptors due to increased blood pressure? Well, back to this equation, and remember this is the cardiac output equation. So cardiac output is equal to heart rate times stroke volume. So stroke volume is the amount of blood you squirt out of each ventricle with each contraction. So what happens is that this baroreceptors, when you have increased blood pressure, what they're going to do, and this can get kind of confusing. So cardiac inhibitor centers are these clusters of neurons that inhibit cardiac activity. And so what they're doing is actually, so kind of think of them like the brakes of the heart. And cardiac accelerator centers, well, what accelerates your car? The gas pedal. So what this is saying is you're stepping harder on the brakes, but you're easing up on the gas. What is that going to do to your overall rate of your heart? So let's just, I like math and I like representing it as mathematical equations. Let's just do examples now. Don't memorize these numbers specifically, but let's establish a baseline. Say before you had that increase in blood, or say this is our current cardiac output. So we have an increase in blood pressure, and say your heart is kind of beating kind of fast, you have a lot of sympathetic activity, and your stroke volume is around on average it's like 70 mils per beat, but say you're heart is working a little harder, and in this before state, before you start doing all of this, it's kind of like, okay, your heart is beating a little faster than normal, and it's pumping out a little more blood per beat than normal. So again, to get cardiac output, just multiply those two numbers and you get 9.6 liters per minute. Now, what if we step on the brakes and ease up on the gas? So if we ease up on the gas and slow down our heart, well, now we go lower our beats per minute. And say we're not going to have the heart squeeze as hard. Now we're going to have the heart like, okay, you don't have to work as hard, you don't have to have, or you can have weaker contractions, not as forceful as we had before. So if the heart relaxes and doesn't contract as hard, it's going to pump out less blood with each beat. So let's take this new product. So what is 80 times 60? That would be 4,800. Convert to liters, that would be 4.8 liters per minute. So what do we notice about the cardiac output? So this was it before, when our heart was beating fast and contracting hard, versus when our heart slows down and contracts a little less forcefully. Well, now we notice that our cardiac output decreases. And back to this formula with hemodynamics. So flow is equal to the pressure drop over resistance, just by simple algebra. And when we were teaching this once, and the students were like, how'd you get that? All you do is multiply by resistance on both sides of the equation, and we get this new equation. Now, what happened here? Well, our cardiac output decreased, again, because we decreased our heart rate and stroke volume, but there's another part to it as well. So if we decrease the cardiac output, we're going to decrease pressure. That goes hand in hand. Now, with the vasomotor center, that is going to cause vasodilation. So again, dilation is going to be increasing in diameter. So what happens when you increase the diameter of a blood vessel? That lowers the resistance as well. So if you lower the resistance, now you're going to lower the pressure even more. So this is what happens. You reduce the flow, you also reduce the resistance, and this is how you compensate for increased blood pressure. By lowering both of these, you decrease your body is able to decrease these using these baroreceptor reflexes. So this is why the blood pressure drops in response to this increased blood pressure, and then you go back to a normal range of blood pressure. Now, how about the opposite case, decreased blood pressure? Well, you're going to have less firing and activity of these pressure sensors, and then what are you going to do? So remember, our cardiac inhibitors are like the brakes of the heart, the cardiac accelerators are like the gas pedal. So you're going to ease up on the brake, you're going to step on the gas. So back to this equation, what would that look like? If we start off here, like say we have like on the higher end of normal, and we have this is kind of a low stroke volume, or not too low, but let's start here. So what would have, nice simple number, we have around 5 liters per minute cardiac output. But what if we have our heart beat faster and our heart also contract more, pumping out more blood with each beat? Now we bump this up to over twice in this example over here. End result, increased cardiac output. Let's use the same equation. Increased flow, increased pressure. But that's not the only part. This third leg of this, what we have is increase in this vasomotor center, and again another cluster of neurons that innervate these vessels. So it's going to trigger the smooth muscles in the vessel walls to constrict. So again, remember, when you activate muscles and cause them to contract, they get shorter. This causes vasoconstriction if we're talking about the smooth muscles in our blood vessels. So just like putting on a very tight belt or a tight piece of clothing, that increases the pressure. So we have a double dose of increasing the pressure. So in response to decreased blood pressure, we have our heart beating faster, but we also have a little constriction to help increase the pressure and maintain that kind of blood flow throughout our body. So this is why we have this homeostasis. So again, it's like, are you going to slow down the heart? Are you going to ease up on the vessels? They have to kind of work in conjunction to maintain blood pressure in your body. Okay, next section. So what we're going to do is talk about hormones very briefly, and if you want more details about these hormones, there's also the resources in the book as well. So these are the hormones. There are many that kind of potentially affect blood pressure, but I want you to know this list of hormones right here. Now I'll go over briefly because these might look very familiar, and yeah, we already covered like at least 3 of these or 4 of these. So epinephrine and norepinephrine, aka adrenaline and noradrenaline. So remember that they are made by the adrenal medulla. So the hypothalamus sends neural signals to the adrenal medulla via the sympathetic nervous system, and the adrenal cells in the adrenal medulla, they're going to produce epinephrine and norepinephrine. And what they're going to do is that you have adrenergic receptors. So adrenergic receptors, well, epinephrine and norepi, they bind to these adrenergic receptors. And on blood vessels, like the cartoon I have here, what they do is actually constrict. So a mnemonic you can use is like alpha 1. So alpha 1 constricts. So alpha is going to constrict the blood vessels. So that's going to increase blood pressure. And some people think like, wait, if we're constricting, aren't we reducing the radius and decreasing blood flow? So things that you want to constrict enough that you kind of actually, well, it depends on where you have these blood vessels. Sometimes you do want to constrict it to the point that you stop blood flow. But if you have low blood pressure, constricting it may actually provide an additional boost in pressure. So it's kind of like a little trade-off. You don't want to constrict so much, or depending on the situation. If you constrict too much, you stop blood flow, but a little constriction can increase and bump up blood pressure. Now, what we have here with norepinephrine and norepinephrine is they're going to cause constriction, so that can cause an increase in blood pressure because, again, you're kind of like, it's like putting on tight clothes. You're kind of squeezing the walls and squeezing the contents. That increases the pressure. Now, what about the heart? So the heart also has receptors, and there's beta 1 and beta 2, but beta 1 is the dominant one. So beta 1 adrenergic receptors, still responds to adrenaline, right? So what happens when epi and norepi bind to these receptors? They cause the heart to beat faster and also beat stronger. So that's going to increase cardiac output. Increased flow means increased pressure as well. So this is why epinephrine and norepinephrine, they bump up blood pressure by stimulating the constriction of blood vessels, but also increasing heart rate as well. And this is, again, remember that those are classic hormones and the symptoms we see in our sympathetic activity, like I'm having right now, trying to get through this. But again, this is why your heart beats faster and stronger when you have that sympathetic activity. Antidiuretic hormone, back to our pituitary gland. So remember that it's also called a vasopressin as well. And vaso, that now means vessels. And pressin, sounds like pressure, right? So this makes more sense now. It's like, oh, increased pressure in vessels. But how does it increase pressure in vessels? So remember that antidiuretic hormone prevents diuresis. Diuresis is the production of urine, but antidiuretic is going to put the brakes on that. So you're going to produce less urine and more concentrated urine. So if you have diuresis, you're going to lose water, you're going to lose blood volume because, again, you have your plasma, and the bulk of your plasma is water. So if you lose water, you're going to lose blood volume overall. So if you lose volume in your blood, you're going to have decreased blood pressure. Now, antidiuretic. What is the exact opposite of this? So if you have antidiuretic effects, instead of losing water, you're going to hold on and retain water. Instead of losing blood volume, you're going to have increased blood volume because you're holding on to more liquid and water and more extracellular fluid. And you're going to have increased blood pressure as well. Because again, so this is why anti-ADH or vasopressin, it's actually a pressor. It increases your blood pressure because, again, you're not losing the blood volume or water volume. Therefore, you're not losing volume from your blood, you're not losing pressure. So this is kind of one important function of antidiuretic hormone. And now let's talk about this big old thing right here. So the renin-angiotensin-aldosterone system, sometimes called RAS, or sometimes spelled with one A, but I'll use this double A because aldosterone is involved. So it's not just renin and angiotensin. But what it involves is like all these organs, but all the organs and all the hormones involved in this system are involved in blood pressure. I'll do a brief walkthrough. So I think this is from Encyclopedia Britannica. I think this is a lot more simplified, and I think a better place to start for compared to that Wikimedia Commons version. So ADH suppressing drugs. Yeah, so you can also look that up as well. So that's the cool thing about hormones, knowing how hormones work. If you have something that acts like a hormone, you can cause effects like that hormone in the body. If you have something that blocks that hormone or blocks the receptors for that hormone, you can undo or reverse or decrease the effect of that hormone or cause like opposing effects of that hormone in the body. So that's why knowing hormones is very powerful as well. So I think this is a good way I like this one because it kind of shows it more simply. So what is aldosterone? Again, what type of hormone is it? Peptide? Is it a monoamine or a steroid? 4 rings, probably a steroid, right? Okay, so it's a mineral corticoid, and mineral sounds like minerals, right? So what is a mineral? What are the minerals that we need in our body? So one of the minerals we need in our body, well, we have sodium, potassium, but if we're just talking about sodium, what is aldosterone going to do? It's going to target our kidneys, and our kidneys produce urine. So if you have aldosterone added to the equation, it's going to tell the kidneys, hey, let's hold on to water, let's hold on to sodium. Now, what's sodium going to do? Well, if you have a large absorption of sodium, or increase in sodium being reabsorbed and kept in your body, that's going to increase the sodium concentrations in your blood. That's going to increase the osmolarity. And if you don't remember what osmolarity is, go back to my osmosis lecture. You have to absolutely understand osmosis to understand blood pressure and the kidney when we talk about later on the semester. So basically, if you have things like salts, sugars, or just like oncotic pressure, the more concentrated you have of these solutes that attract water. So if you have two solutions, one is dilute, one is more concentrated, the more concentrated solution is going to draw water toward itself. So if you have increased osmolarity and increased solute concentration of sodium in your blood, it's going to hold on to water and attract water from the surrounding tissues at a faster rate. So increased blood salt osmolarity is going to increase that blood colloid osmotic pressure. So again, that ability for blood to reabsorb water back into your vessels. Why? Because now you have increased sodium in your blood. So increased sodium in your blood is going to allow it to draw more water into your blood. So increased BCOP means more water reabsorption. More water reabsorption, now you're introducing additional volume and molecules inside your vessels. That's going to increase your blood pressure. So the overall effect of aldosterone is to bump up your blood pressure. Now renin. So renin, I put a little asterisk there, so it is a protein, but in terms of the RAS system, it's an enzyme. So it's not, there's some papers that say renin is a hormone and has a receptor, but I think this is just one lab group, and I don't think they've published things for a while. So renin itself does not really act like a traditional hormone. What it is an enzyme that converts a protein called angiotensinogen into angiotensin 1. So that's a Roman numeral 1, not an L. Now, again, this is why I put that little asterisk, because even though it is a peptide, it is a protein, it's not a typical hormone. Its overall major role in the RAS system is to be an enzyme that converts angiotensinogen to angiotensin 1. Now, what if there's angiotensin 1, is there angiotensin 2? And yeah, there's actually multiple variations of angiotensins, but angiotensin 2 is a really important one. So angiotensinogen is actually a very, very large polypeptide. So it's the starting peptide. So when you have that, again, you have with going from DNA to mRNA to protein, you have your transcription, then you have your translation. So the initial product from this translation is angiotensinogen. So it's actually a super long protein, and that's why I put a little dash here, because otherwise it would take up the whole screen. So you start with this peptide, and then renin comes along and actually cleaves off most of it. So it kind of actually breaks it apart. And this small part over here is angiotensin 1. So most of this is actually not the part that actually has cardiovascular effects. It's just a small portion of it. Then angiotensin 1 is not the final product. There's another step that has to happen. So different enzyme called ACE1, what that is going to do is going to actually cut angiotensin 1 and cut some of these amino acids off. And it's going to convert angiotensin 1 into angiotensin 2. So again, not LL, it's a Roman numeral 2. So angiotensin 2 is the one that has the powerful effects on the cardiovascular system and blood pressure. So it can actually be processed further, but that's more like a PhD or med student level stuff. Angiotensin 2 is definitely the one you should know, especially if you're going to nursing school or pharmacology or anything medically or any of the allied health occupations. So angiotensin 2, what is that going to do? Well, notice that there are, at least in this diagram, 5 main effects. One thing is going to increase sympathetic activity. What is sympathetic activity going to do? It's going to cause vasoconstriction. Again, remember, sympathetic activity is going to flood your system with epinephrine and norepinephrine. So you're going to have constriction of the blood vessels. You're going to have your heart being faster and stronger, so you have increased cardiac output. Both of them are going to bump up your blood pressure, right? So what else does it do? It also tells your body to retain water. So it also targets the kidneys, telling it to hold on to water. So you're going to have increased blood volume. And increased blood volume, it means increased pressure. Increased sodium absorption. What happens if we have more sodium in our blood? More sodium in our blood, more blood osmolarity, more BCOP, more ability of reabsorption of water into our blood. Therefore, more blood pressure. Increased aldosterone secretion. And this is why I talked about aldosterone. You're going to have increased reabsorption of both sodium and water. You're going to increase your osmolarity, and you're going to increase your volume. So you're going to have increased blood pressure. And you're also going to increase your ADH production. So again, ADH is going to tell your kidneys to reabsorb water, therefore increasing your blood volume, increasing your blood pressure. So this is why angiotensin 2 is a very, very powerful pressor hormone, because it increases all of these things that end up increasing your blood pressure. So it's kind of like a multi-pronged attack to increase your blood pressure. So that's why angiotensin 2 is a very powerful hormone you definitely should know. And there's something called ACE inhibitors. So ACE inhibitors are going to inhibit one of those enzymes along the way of making angiotensin 2. So what it's going to do is inhibit that angiotensin converting enzyme, that ACE, as in by inhibiting that ability, the production step of converting angiotensin 1 to angiotensin 2. If you stop at angiotensin 1, you're not going to have angiotensin 2. Because why? You messed it, you're blocking the part that helps to convert that angiotensin 2. So what happens? Less angiotensin 2 lowers your blood pressure. So this is one thing that can help to lower blood pressure, is by blocking hormones. So this is why knowing, just like mentioned chat, sometimes if you block these hormones, you can have the opposed effects these hormones have. And then, let's see, angiotensin 2, and then ACE2 converting 1 is not the same thing as ACE2. So this is more like the PhD and like med school level stuff. So there are other things, and that's why it's like, okay, sometimes they have different numbers attached to it, and I don't expect you to know all of this part right here. But what I'm getting at here is that this is the classic pathway, and don't get confused with this side pathway if you happen to come across it in the literature. This is what I want you to know. Angiotensin is converted by renin into angiotensin 1. Angiotensin is converted by ACE into angiotensin 2, and then that's going to cause that increase in blood pressure. Now, very topical, like the thing about this is that we have vasoconstriction and increase in blood pressure as well. So angiotensin 2 binds to this receptor called the angiotensin receptor 1, but the cool thing is that we also have these drugs that block the receptor. So instead of blocking ACE, it actually binds to the receptor and blocks it itself. So maybe I'll include that in a future lecture or future years. But the thing is that by kind of like messing around with angiotensin 2's production or messing around with the receptor that carries out the activity of angiotensin 2, you can lower someone's blood pressure by blocking that overall activity. And why I'm including ACE2? Because this is actually very interesting, because I don't know if I have time to talk about COVID later on this semester, but this is more related to the COVID part. And notice that instead of increasing blood pressure right here, what angiotensin 2 is angiotensin, the second receptor, the angiotensin receptor 2, that actually has opposing effects, but maybe when we get later on semester. let's talk about the respiratory system. I know I'm going really quick, but we have to get through this. Okay, so then main function of the respiratory system is gas exchange, and which gases in particular? So what we want to do is bring in oxygen from the environment into our lungs and distribute it to our tissues. Our tissues are going to consume the oxygen, create carbon dioxide. So we want a way to remove carbon dioxide from our tissues and our body and expel it back into the environment. So that's the main function. But why do we need oxygen? Well, we think of the things that, if you might remember, if you were here for AMP1, that ATP is involved not for all the processes in our body, but for almost any chemical or most of the chemical processes in our body that require energy input. ATP is an easy way for them to get energy to drive these chemical reactions. So again, why do we need, what is the powerhouse of our cell? This thing right here, right? So our mitochondria is the powerhouse of the cell. And why are they the powerhouse? Because they produce the ATP. So what they're going to do, or majority of the ATP, I should say. So this is going to come up later on in the semester, but what I want you to appreciate at this point is that we have all these nutrients and they're feeding into the mitochondria, and this is the infamous citric acid cycle, aka Krebs cycle. So what's going to happen here is that you have all these nutrients being converted through metabolism into chemical compounds, and then out of this electron transport system, which needs oxygen, you're going to create ATP. But as a byproduct, you also create carbon dioxide from the mitochondria. So you're consuming oxygen, the mitochondria need oxygen, but it's also producing carbon dioxide. So this is why we need to bring in oxygen, but we also need to get rid of carbon dioxide. Otherwise, we would have a lack of oxygen in our body, and we have carbon dioxide building up in our body. And this might be familiar if you take an AP Bio or any intro to bio. So what we have here is glucose plus oxygen is converted into carbon dioxide, water, and ATP, or energy, or sometimes it's just an energy. But if you had a really good teacher, they don't just say it's just ATP as energy. They might also say that heat is part of the equation. Heat is energy, and heat is a byproduct of mitochondrial activity. But that's more later on in the semester. So let's talk about the anatomy of the respiratory tract. So again, I had to talk about the cellular stuff to explain why we need oxygen. Okay, so these are the main structures, and you might be like, wow, this is an entire respiratory system? So it's pretty simple, and that's what we're seeing here. So that's one thing you'll notice is, like, a lot of times the gross anatomy and what we can see with our eyes is pretty simple for a lot of these systems we'll cover in the next rest of the semester. But how they function on the molecular level and the physiology is a little more complicated. So what we have here is like the upper respiratory tract, and depends on the textbook, but I think both textbooks are pretty consistent. The part where it's sometimes ambiguous depending on the textbook or resources, sometimes they include the larynx in the upper respiratory tract. For this class, let's consider it this. This superior border of the larynx is the limit between the upper respiratory tract and the lower respiratory tract. So let's consider the larynx as the lower respiratory tract, and then the pharynx and everything that comes before that is the upper respiratory tract. And what we have here is so here we have our nasal cavity and oral cavity. And with our nasal cavity, what we have are a bunch of bones, and also not just bones, we also have cartilage as well. So bone and cartilage are supportive connective tissues, but bone is the mineral matrix, especially the calcium phosphate and all the other minerals in our bone. That's why when we die, we leave our skull behind. But if you look at a skull, why does it have that triangular opening? Well, all this cartilage that made up our nose when we were alive decomposes much more readily than bone matrix. So this is why when you look at a skull, we have that opening, that triangular opening. And if you have pen and paper, you can, if you're watching from home, maybe take out pen and paper. I'm going to do a very simple drawing activity. It doesn't need to be very fancy. You just need something to draw on and something to write with. Now, before we get there, and I do have it a little blurred here because and every time I show this in person, sometimes, a lot of people are like, whoa, actually, even when I first saw it, I was like, wow, This is a pretty intense picture, but I think it really does a good job of showing the structures, the sinuses, the conchae, the meduses of our nasal cavity and upper respiratory system. So what they did here is like they actually took a slice of someone who donated their body and just cut this part right here. So we're looking on the inside of someone's face over here and the associated respiratory structures. Now what we have is the ethmoid bone, and the ethmoid bone is going to, and then we have the vomer, forming the bony part of what we call the nasal septum. So just like the septa in our hearts divides the left and right chambers, same with the nasal septum. It's going to divide our nasal cavity into left and right. Now, with this nasal septum, the ethmoid makes up that upper superior part, the vomer makes the inferior part, and then you have these scroll-like projections called superior nasal concha. Again, in this image, it's kind of obscured a bit. Download the slides if you want a clearer picture. So again, like a conch shell has that kind of like spiral shape, or it's like if you know like a turban shell has a spiral shape. Sometimes these are also called turbinates because they're like a turban like shell kind of shape. And then we have our middle nasal concha, and hey, what's the opposite of superior? We also have our inferior nasal concha. But the thing about the ethmoid, the superior and middle are actually extensions of the ethmoid bone. The inferior nasal concha actually comes off from the side, so it's actually not really considered part. It's actually not considered part of the ethmoid bone. In most textbooks, it's considered its own pair of bones by itself, because it's not quite part of any other bone. It's kind of its own structure. Now, what we have is, like, if you remember our bone markings and landmarks, that a meatus is like a pathway or a passage. So between these conchae, we have meduses. So these are where the air flows. So again, the conchae are the ones that are the swirly structures lined with bone and membranes. And then the meduses are these passageways between each of these conchae. So just like we have 3 pairs of conchae, we also have 3 pairs of meduses. Now the nasal conchae right here. Here's the drawing activity. So here again, remember when we die, then what happens to our nasal cavity and our nose? Our nose disintegrates. We leave this triangular shaped hole. So we'll draw a triangle at first, and the ethmoid is going to be the top part of that triangle. So it's going to form the roof of the nasal cavity. Now our vomer is going to form the inferior bottom part of this nasal septum. So this is the nasal septum over here. Now what you're going to do is draw the hard palate, and why isn't it a specific bone? It depends where you're taking the section. Are you going to do it more anterior and toward the front? You'll have more of the maxilla. As you transition toward the back, then you'll get more of the palatine bone. So again, that's why I'm just saying it's the hard palate, because it's a bony structure forming the floor of this nasal cavity. Now back to the conchae. So we have our pair of superior nasal conchae, then our middle nasal conchae, and make sure they're attached to the ethmoid because they are extensions of the ethmoid. And then we have our inferior nasal conchae, which are their own pair. They're not part of the ethmoid. So and they're inferior because they're bottommost of these 3 pairs of conchae. And what are their whole purpose? Well, this is why they look like curlicues. They're there to kind of swirl. So you're not going to just inhale air and go straight into your respiratory tract. They actually kind of help to slow things down. Or if you've lived in a cold environment or done any winter sport where you're in a very cold area and you're breathing in this very cold air, it hurts if you kind of breathe in that air like without really warming it up. So the cool thing about it is that it allows you to warm up the air, but also humidifies because the membranes in here have a lot of moisture. So it also helps to, if you've ever been in a very arid area, you might notice that your throat and your airways get very raw and kind of like sometimes painful if it's very arid in the area that wherever you're living in. So it helps to humidify. So the conchae help to humidify. They help to warm it up. And you also have a lot of mucus. So if you have like particulates and dust or maybe some microbes, it also helps to trap these as well and prevent it from getting further in your respiratory tract. So this is what they're there to kind of slow down things, but also trap things and make things and condition. So it's kind of like air conditioning for your respiratory tract. That's what the conchae help to do. So here's the upper airway, and there are many structures, and part of your homework is based on this as well. So here, maybe I don't have time to talk about this real quick, but with the brain freeze, it's really cool. Like, what's a simple life hack you can do to get a brain freeze? Like, if you like ice cream like me, so you eat it too fast and you're like, oh shoot, I have this like brain freeze that really hurts. So one thing you can do is take these, remember that your nasal conchae are involved in warming up the air. So what you can do is take advantage of your nasal conchae and how they warm up air as well. So there's something called the trigeminal nerve, and what happens when the trigeminal nerve is also very important in detecting pain. So that's why dentists often try to numb this nerve when they're doing dental work. But what if you're eating ice cream? Well, the thing is that extreme temperatures can also cause pain, so they can also trigger the trigeminal nerve to carry sensations of pain to your central nervous system. So one thing you can do is actually press the tongue up here against your hard palate, and then by doing that, what you're going to do is help to warm your hard palate. And by doing that, you're going to help to prevent that cold or warm up that cold sensation that was being done by the ice cream swirling around in your oral cavity. And your nasal conchae and warming up that air is going to help to warm up that trigeminal nerve so that it's no longer as painful. So this is one way you can help to deal with that whole brain freeze, so to speak. All right, so now we're done with the nasal cavity and oral cavity. Again, this is why, now this is less relevant now that our mask mandates are ending. But when people wear masks like this, like when they wear it like this, is like, hello, your respiratory system is connected to both your oral and nasal cavity. So that's why you have to have your mask above your nose, right? But anyway, that's another thing. So what back here? So again, they're all connected eventually to the same tube. So that's why it's really ridiculous when they have their mask below their nose. But what we have here is the back. So pharynx is approximately your throat. So it's not exactly one-to-one, but you can think of it that way. So notice that it's a kind of important bridge between this, your nasal cavity, your oral cavity, and where your lower respiratory tract. So the pharynx includes all these structures, your nasal pharynx, and nasal sounds like nose, right? Oral pharynx, hey, notice the oral pharynx is right where the oral cavity connects to the pharynx, and the laryngeal pharynx. So this together, so we have our nasal pharynx, our oral pharynx, and our laryngeal pharynx. So this is an easy question, or just knowing the structures. Think about it. Which is most going from top to bottom to going from superior to inferior. Your nose is above your mouth, above your larynx. So now you know the order of these subregions of the pharynx in order, because unless for some reason your mouth is above your nose or your larynx is above your nose, but just by knowing where these things combine, you know the order of these structures. Okay, now from the pharynx, let's go on to the right below that, and let's talk about the border between the upper and lower respiratory tract. So now we're going to go here. So what we're having here is eating. And have you ever had it where you're eating too fast or drinking too fast and it goes down? Somebody says, oh, it went down the wrong tube, and you're coughing, you're hacking, and everyone thinks you have COVID and it's super embarrassing, but you're like, no, I just ate too fast. Well, maybe because you ate too fast and went down the wrong structure. So your oral cavity is the common gateway to both your digestive and respiratory system, but what helps to make sure that it goes down the right tube? Well, you have something called the epiglottis, and it is made out of mostly cartilage. And what it's going to do is, if you're trying to swallow and eat and drink, you want that epiglottis to cover your respiratory tract so that you don't have it entering so whatever you're eating or drinking doesn't enter your airways and block your airways, because that would cause suffocation. But it's also like if trace amounts get in there, that's why we also have our coughing reflexes as well. Now our epiglottis, what we have is notice that with the epiglottis, it has this membrane, but also this hyaline cartilage over here. But around our larynx, we also have a bunch of cartilage that help to give it a structure and rigidity, and some of it. So yeah, basically the cartilage is very important for the overall strength and structure of the larynx. Now our larynx is, you may have also heard it called our voice box as well. And what we have, because it's not like a literal box, but it is kind of a semi-rigid structure that does help in the production of our voice. So here is our upper airway, and here is the vocal folds and the glottis. So epiglottis is right above what we call our glottis. So remember that epi means above or outer, so just below the epiglottis we have our glottis. Now let's look at our glottis, and what we have is our, this is the base of the tongue. But now we have these folds, and this glottis is part of these folds. So here we have the vestibular folds, but the part that's next to the opening is what we call our vocal cords. So the vestibular folds, they help in moving these, but they're not actually the part that's part of our true vocal cords, are the ones that are involved in our voice. And here we have, this is the Martini version. I think it's a little better at showing the structure of this as well. So yeah, we have our vestibular folds, but the vocal folds, these are the ones that vibrate, and they help to produce our voice when we're speaking as well. So if you remember, if you were here for AMP1, you know that vibration is sound. Well, same with the sounds we produce. It's due to the vibration of air as it rushes past our vocal cords. And so I like to, and if you were here last semester, you know that when I talk about the cochlea and about the basilar membrane inside our cochlea, that I liken it like a string instrument, because again, when you have a string instrument such as a violin or guitar, how does it produce a sound? You cause a vibration in the string, and depending on the properties of the string, how tense you have the string, the thickness of the string, that affects the pitch of the sound that's made. Same with the vocal cords right here. As air rushes through it, and depending on the thickness, how tight these cords are, how smooth these cords are, that's going to affect the pitch of our voice. So here we have our vocal cords, and what happens is, like, okay, as we breathe out and we're producing speech, the air is going to rush past here, but depending on how tight, how thick, how long these vocal cords are, that's going to affect our pitch of our voice. And that's why if you have a larger larynx, and that's why in general men have lower voices, because they tend to have larger larynxes, so longer vocal folds as well. So the longer the vocal folds the more stiff it is, the thicker it is. Just like how if you have a very thin string versus a very thick string, the thin string is going to have a higher pitch than a thick string. Or like if you're playing a stringed instrument, the more you choke up on the neck of the instrument, and the shorter you have distance between between the fingers and the bridge or it's been a while since I took orchestra. But the more slack you have, the lower the tone, the more tight it is, the higher the tone, right? So same with that. Now over here, it's actually pathological over here. And I don't know if we have time to talk about this, or actually, like, back to our vocal folds. So the glottis is open, and what we see here is the glottis is closed. So whenever you're opening and closing your glottis, you're actually causing an interruption in air every time you close your glottis. So if you're at home, try to do this on your own time. Or actually, like, I mean, we just have chat. We don't have like voice chat here. But say these locations in your mind, or just say it out loud, or maybe don't say it out loud if you're going to attract funny looks. Okay, so say this location. So even locals sometimes say Honolulu, but Honolulu, right? How about this location? Say Punaluu. It's Punaluu. So it's kind of a little break. And try to say this location. And I love seeing people who don't know Hawaiian saying this location, because they get super, they're like, but sometimes they get on the first try. But what we have here is like ka'ava. So that's what, notice that it's like not ka'ava. So you have to break it up. You have to say ka'ava. Now, what is this? Well, if you're taking Hawaiian, I forgot what the course number is, but you'll eventually know that this is called okina, or a glottal stop. So it's not just a punctuation mark, it's actually a consonant. Because why? You're actually changing the structures of your respiratory system to produce the sound. So what's happening with this okina? Every time you do this glottal stop, you're actually breaking up the airflow using your glottis. So by doing that, every time you do a okina, you're closing that glottis. So this is why to produce that, you actually think of it like, I'm not actually producing that sound in my mouth. I'm actually producing that break like punalu. It's actually in your throat. So that's why it's a glottal stop, because you're actually opening and closing that glottis like we're seeing here. And let's see, vocal nodules. I don't know if we have time to talk about this, but, or maybe we're near the end of this lecture, but let's talk about vocal nodules. And it just escaped on me. What the heck? Okay. Vocal nodules. Maybe we'll skip over that, but yeah, if you ever watched like maybe it's getting kind of dated, but you might have seen it as a kid. But you might have heard, if you watch that movie Pitch Perfect, they talk about vocal nodules and why might that be very harmful to a singer's career. Well, the thing is that these vocal nodules, because our vocal folds are very important in our speech, the thing is that with our vocal folds, the more smooth they are, the smoother our sound of our speech. But if you have all these nodules, it's going to cause this turbulence and this bumpiness in our vocal folds. So this also will help to, like, say you have like you're a messy eater and you're playing your guitar and you get like gum on your strings. That's going to dampen the sound as well. So this is why vocal nodules can affect someone's voice. And vocal nodules are actually kind of like scar tissue, because again, scar tissue and fibrosis happens when our tissues are subject to a lot of damage. So this is why people's voice, once they develop those, they can start to have less vocal range and also have changes in their quality of voice. And if you watch Pitch Perfect, they get the surgery, but this does not mean the vocal nodules cause lower vocal pitch. Remember, that's what happened after she got the surgery. But what's then thing here is that vocal folds are very important to our voice, and no vocal nodules or any pathologies that affect our folds can also affect our speech as well. Oh, so here's like Julie Andrews, and you probably saw this movie as a kid. So the thing is that Julie Andrews, she's still alive, she's still kicking, she looks pretty good for her age. And then, but the thing is that why doesn't she perform anymore? Why doesn't she sing? She was the voice back then. Well, the thing is that she also developed these nodules, and she actually, this is why she doesn't sing anymore. She went for surgery to correct it, but the surgery was botched. So a botched surgery stole Mary Poppins' voice, and that's why she doesn't sing anymore. Crystal clear before, but I haven't heard how it's not tried. I don't think it was, and maybe there is a clip of her. I haven't seen any clip of her post-surgery, but yeah, she never sang again after that. Okay, let's try to finish this last section. Maybe we can get through this. So major respiratory structures. So now let's get to lower respiratory tract. And what we have here, right inferior, is the trachea. And we have all these tracheal cartilages. So notice that cartilage is very important to the structure of the respiratory tract. And it's actually hyaline cartilage. So again, there are three types of cartilage. We have our elastic cartilage and fibrocartilage, but that hyaline cartilage is that one that's full of that hyaluronic acid. And so cartilage is not as rigid as bone, but it is pretty strong. It is a supportive connective tissue. Now if we look even further closer to this, notice over here we have the pseudostratified columnar epithelia. So let's zoom in on that a bit. Now between these we actually have these things called mucus cells, and what they're doing is producing mucus. So that's why, even though you can't really see it in this previous picture, we actually have a small layer of mucus over here lining our respiratory tract. And we also have something called cilia that help to move, and this is why they're cilia columnar epithelia, because the cilia are actually mobile. So what they do is actually kind of like move the mucus across their surfaces. So what they're going to do is move mucus out from the base of our lungs and up toward the pharynx. So it's kind of like a little escalator or elevator. So what we have here are these little like dirt particles or bacteria or foreign things that get in our respiratory system. So the mucus is going to help to snag it, but also carry it up and out of our respiratory system, because we don't want something blocking our airways, and we also don't want infectious particles hanging out in our lungs. So yeah, that's why we have our cilia and all this mucus. So mucus is there to help to trap, but also move stuff as well, in conjunction with the cilia. Now, yeah, so it looks like in this scanning electron microscope, you notice that it's like there's a lot of these cilia and looks like one of those like 70 shag carpets. Well, that shows you how important it is to move this mucus up and out of our respiratory system. And here we have the larynx, or not the larynx, but the trachea. So what we have here is actually a ring of cartilage, but notice that it's not all the way completely circular. So it's actually C-shaped. And it's not completely closed because if it was, then you couldn't really change the shape. The cool thing about the C-shaped rings of tracheal cartilage is that you can cause them to contract and expand like this. And why is that? Well, it's due to this tube right here. So this is actually more anterior and toward the front, but over here toward the posterior is our esophagus. So our esophagus, well, yeah, take my word for it, it's the esophagus. So that's where our food and drink goes through. So the cool thing is that when we're swallowing something, this is going to expand. But now that since we have this little gap over here, that allows a little wiggle room and room for expansion of the esophagus. But if it was a complete O-ring, then we wouldn't really have that flexibility if these tracheal cartilage were full, complete rings. And then tracheal cartilage, they're also like the little ribs on a vacuum hose. So the thing about vacuum hose, why does it have all these ribs? One, to help with the structure, and two is like when you have air rushing through a tube, that actually lowers the pressure inside that tube. At least like the pressure that's pushing toward the outside. So the cool thing is that if you have all this air rushing through the tube without any support, this is actually going to collapse the tube. And that's something that, I don't know if I have time to talk about wheezing and asthma, but take my word for it that they also help to keep the airways open as air is rushing in and out of your respiratory system. And okay, so we're over time. Maybe I can just end on the gross anatomy of the lungs. Again, if you have another class after this, by all means go to it. But gross anatomy of the lungs, this is a cadaver lung, and I'm like, ooh, I mean, it's a real one, but I think it's kind of hard to see it because it's pretty dried out looking. But what I'm trying to make it help you, or what I'd like you to appreciate from this is that it's not coincidental that the heart is right next to the lungs. Again, what's going to deliver oxygen and oxygenate the blood that leaves your right ventricle? So it's a very short stop to the lungs. So your lungs and heart work together. That's why I'm putting them both together for Unit 2. Now, if we turn it this way, so here we're looking at the front view of our lungs. Let's turn it this way. So if we turn it that way, yeah, look at the heart. So this is a cross section. So if you took this guy's chest and looked at it from the top, notice that the lungs are the heart is nestled right among the lungs right here. So that's why this view is really cool. Now with the lungs, let's talk about the general anatomy of the lungs. So notice that the lungs, are they completely symmetrical? And if you look at this, if you're watching at home, think about it. Are they completely symmetrical and mirror images? They're not. So what are some images so it's kind of like, look at the differences. What are the differences? Well, look at the lobes. Count how many lobes there are. Let's see, here on the left lung, we have a superior lobe and an inferior lobe. But on the right lung, we have a superior lobe, a middle lobe, and an inferior lobe. And is there a middle lobe on the left lung? Not really, right? And notice like these cleavage lines between the lobes, that we have two lines here and one line here. So there's no middle lobe on the left lung. But also notice that in terms of their overall shape, notice that this part of the left lung is scooped out. And why is that? Well, the thing is that, remember that what's kind of poking into that left lung, what's right in the middle of these lungs? We have our heart, but is our heart completely central and just symmetrical in our chest? Remember that our heart is not only slightly offset to the left, it also points towards the left. So you need room for the heart. That's why the left lung also has that little cardiac notch. Now this picture is a little difficult. So say your lungs are normally like this. So what we're looking at is the lateral view. So pretend you're looking on the outer side. So we're kind of turning our lungs toward, like we're looking at the side of our lungs. So now you can see the divisions and these fissures between the lobes more clearly, and that's what we have here. But now let's go from the side view and go toward the inner view right here. So with this inner view, now we see more of that cardiac notch in the left lung, and we see all the connections with those pulmonary arteries and veins that lead to and from the heart and to the lungs as well. And I think this is a good part to stop. And yeah, so let's talk about the bronchioles when we come back on Friday and talk about the substructure. So now we're past the larynx and trachea, and now let's get to all these branches. Like when I saw this last year, I was like, yo, I love this. Like, actually, are those freaking diamonds? Holy crap, how expensive is that? But yeah, I was like, yes, I love this like bronchial tree lung. I mean, it's like so awesome. So we'll talk more about bronchioles when we come back on Friday.